My name is Chris, and thank you for tuning in again. This presentation I'm going to be talking about was something I had to do for school, focusing on one of the rotations that I was on. So I was on trauma. So without further ado, so this is my tutor session presentation. So we have a 54-year-old man, status post motor vehicle accident, driving at 55 miles an hour. There was positive head strike with a posterior laceration of the head, and there was positive loss of consciousness. And that's how you're going to see written usually on like the lists for all the patients. So the first thing you're going to do when the patient gets into the ED is you're going to do a primary survey. The primary survey has an acronym. The acronym is A, B, C, D, E, and then potentially F. So that's what it breaks down to. So the first thing you're going to want to do is check the person's airway. And the simplest way to check this is to see if the patient is speaking to you. That most likely can be a question on one of your shelves or boards or something. But to see if this patient is speaking to you, if they are, then you know the airway is secure. The airway is patent, and you can move on to the next parts of the primary survey. Breathing is done by listening to bilateral chest sounds, and you'll hear the inspiration. So if they are, then you know that both lungs are okay. At this point, if you see if you only hear one-sided lung sounds, then you potentially should be looking for something like a pneumothorax, a hemothorax, um, stuff along that line. Going down further, you're going to look at circulation. So this is like the person's blood pressure, right? So the thing you're going to want to look at is like their systolic blood pressure. So when they get into the ED, the trauma surgeon or the ED's doc is going to be asking like, hey, what was the person's lowest systolic? What was the person's uh, like meds given in the field and stuff like this. So the systolic is a pretty important factor, and you can do this several ways. So you're throwing on a blood pressure cuff, you can immediately tell right now. If you do hear a pulse, if you do feel a pulse, a brachial pulse, then you know that you're sitting around at least 80. And if you're feeling a femoral pulse, then you know that you're at 60. If you feel carotid, there's something like 40, but you can have like residual effects from like the heart beating, so the carotid is not as good. And you're also going to want to assess urine output, so this potentially could be a catheter. Low urine output is one of the is a diagnostic sign that can show that the person is not having their kidneys perfused. And in that situation, you are going to want to fix that by uh, providing fluids to the patient. Disability is next. This is simply assessed by the Glasgow Coma score, as well as like how they appear when they come into the ED. The GCS is broken up into 3 measured components, and one of them is looking at eyes. The next one is looking at the verbal response, and the last one is motor. So the motor is 6, the verbal is 5, and the eyes are 4. And you can kind of briefly go through it like this. And the things you want to look out for is if it's 8 or less, they can split up your level 1 traumas kind of on that status alone. So if they have a GCS of like 7 coming into the ED, then you're going to be probably intubating them immediately if they're not already intubated in the field. And 3 is the lowest possible score that you're going to be getting for the GCS. You do have like exposure as well, so you kind of just see if like there's any broken glass on the patient and stuff like that. And then F is a FAST, a focused abdominal sonography with trauma. So this is like when you have any trauma patients coming in, you're going to want to assess if there's any free fluid. Now the FAST is a good tool to use, and there's a lot of different scenarios where it's beneficial. So if the person is hemodynamically unstable but has no bleeding, no exterior bleeding, then you're going to want to do a fast and check for potential like pericardial issues or potential peritoneal issues. Now, if the issue is like maybe they have like a thoracic rupture or something like this, the fast scan won't be able to detect retroperitoneal bleeds as much, so you're not going to be able to assess as well for that. Um, One of the downsides of fast, and you'll be able to get this on like I think it's like I don't know if it's like a UWorld question or OME or something, but so the other thing about FAST is like it requires ultrasound in order to understand if there's fluid there or not. So one of the drawbacks is if a person has high BMI coming into ED and potentially needs FAST, then maybe this is not the best choice because you won't be able to get through all the fat. So in that situation, a DPL, diagnostic peritoneal lavage, is required, and you can kind of look up more about how that will go. But just always keep DPL, even though it's kind of been thrown out of practice, always on differential as a diagnostic tool if the person has high BMI. Your secondary survey is going to be coming through, and the acronym you're going to use for this is called AMPLE. And if the patient is alert and oriented and is able to respond to questions, then you're going to want to ask about any allergies to meds, any medications they're currently on, their past medical history, their last meal, like the time of their last meal. This is important for anesthesia and other stuff like this, and the events preceding the trauma. So if the person, classic, 77-year-old male, status post fall, you kind of want to ask, okay, well, do you remember what you were doing prior to the fall? And that kind of will dictate if it's mechanical or like drug induced or, hypovolemic in nature or something like this. And then you're also going to do a head to toe physical exam. So this is where you're going to be, now that you secured airway, circulation is normal, they're able to survive. Now you're going to want to check, okay, are there any other lacerations, any other broken bones, anything that needs attention at this point? So now the person is generally stable right now, and now you're going to be able to assess, okay, are there other things that we need to be consulting for or other imaging modalities that we're going to need for this patient. So the head survey starts from head to toe. And for the head, these are some of the things that you can kind of see. And we're going to be going through kind of what those will look like. And the way you're going to diagnose these is through a CT. So they're going to ask you a lot about this, but your basilar skull fracture. This is like the top three is hemoperitoneum. You're going to do your battle sign, your post-auricular ecchymosis. You're also going to get your like raccoon eyes. I actually saw a unilateral raccoon eye, which is kind of crazy. You're gonna get a fracture right there, so you're gonna want to. That's an emergency right there because that was a pretty powerful trauma in order for that to occur. The CSF, the way that works is if you drop CSF onto a tissue, I think, or something, it'll spread out into this like ring pattern. You got your hematomas, you got your epidural, your acute subdural, your chronic subdural, as well as your intracerebral. So you're going to want to know all of those, where the etiologies come from. So epidural is like crack to your like temporal bone kind of area. Your pterion gets fractured, your middle meningeal gets hit, fast bleed. Subdural hematoma is your elderly patient, your alcoholic, fell, slow bleed, no acute distress. Eventually comes in 2 weeks later complaining of disorientation or stuff like this. Intracerebral hypertension, AKPKD, other things like this. You can have severe systemic issues as well. So you can have associations with like not being able to uh, do certain motor functions. The epidural hematomas also can cause a like counter coup kind of issue as well. So you can kind of get issues where like you're going to get ptosis of a certain eye and stuff. So just knowing which type of hematomas there are kind of important, and there'll be plenty of questions about that as well. Your axonal injury is going to be just a straight like uh, moving back and forth, so the coup counter coup kind of motion kind of rips the neurons. This is at the gray white junction, so you're going to want to look for that. And then you have your concussions as well. So concussions, and there's like kind of varying approach on this, but from what I've understood, the concussion does not necessarily need to have loss of consciousness. But I think for our exam purposes, if you're studying for like your surgery shelf, then I think positive loss of consciousness is required in order to assume concussion and not TBI. Um, but yeah, so concussions like that. So you see a lot of that in like the sports. Your neck penetrating wounds, these are kind of huge. So in order for a penetrating neck wound to occur, then it has to get through the platysma, and the platysma is innervated by cranial nerve 7. So if there's a puncture of the platysma, then you know that you are in a penetrating neck wound. Now, there are a few signs you're going to want to look at to determine the extent and the speed at which you are going to need to respond to a neck penetrating injury. These are called hard and soft signs. And you can look at them on my screen right now, but pretty much the very bottom line is what you are going to do at the very end, and are you going to do a direct OR or are you going to zone the neck? And as you're going through these, you can kind of look, okay, so if you see like bruits or thrills, yeah, sure. You see expanding hematoma, of course. You can also get like this, the active bleeding that has pulsatileness. That's going to be a hard sign as well. Your soft signs are going to be right here as well. Chest tube air leak, dyspnea, stuff like that. But your neck, okay, so your neck is zoned in 3 different areas, and it's zoned in the direction that your carotid arteries flow. And the zones are important because it will determine what imaging or diagnostic modality you're going to use. So if you're in zone 1 down there, you're going to get an esophagram, a bronchogram, and an aortogram. This is because there's all those bad structures down there, right? So you're going to want to look at all of those because those are potential nidus for injuries. Go to zone 2, you can just literally surgically explore that. That's super chill. A zone 1 though, so this is the edge of the angle of the mandible to the base of the neck. That is zone 3, and that's an aortogram because you're going to be worried about those kind of structures up there as well. Now you're going to have your blunt neck traumas as well, and these are going to be your classic like first year med school kind of questions about like the descending tracts, the ascending tracts. Where do your pain fibers cross? Where does your LCST go? Like proprioception and like legs are the nucleus gracsalis and kind of like those things, right? So moving on, you're gonna want to next do like your chest. So starting from the head and neck, now you're on chest. Your chest could have like some blunt issues as well, so you can have rib fractures. You can also have penetrating pneumohemo and second chest wound. Those penetrating issues, yeah, for sure. You're gonna probably notice those on initial primary survey where you're gonna notice unilateral breath sounds. Um, the flail chest, you're going to be able to be able to notice this if the person's using accessory muscles in order to breathe. The breathing is not in concert, like in the effect where when you expire, your lungs go in. So if your chest is actually still expanding or certain parts of it are not collapsing, then you should be concerned for, flail chest. Um, the the definition of a flail chest can differ from OME to Diverhelio and stuff, but the lowest definition was a minimum of 2 ribs fractured in 2 or more spots. The other definitions I saw were a minimum of 3 ribs fractured in 2 or more spots. Either way, you're going to be doing either rib plating or IF, or you're going to want to be looking at like pain management and potential rib setting though. So your rib fracture is going to be your pain management as well as incentive spirometry because you're not going to want to have that atelectasis day 1 progressing to post-op day 3 or post-op day 2 pneumonia. Yeah, so right here you got your pneumothorax. You're able to see like a part of the lung more clear, and there's your pleural white line. Thoracostomy is going to be your treatment of choice. Your hemothorax also is really obvious to see because you're going to see the blood pooling there. In order to do this, you're going to want to put a chest tube in, drain all the blood out. And there are certain criteria for this. Okay, so if you have a lot of blood in you. So if you drain over 1,500 ml of blood, then that is indicated for shock level 3, I believe, which means that it's actually a pretty significant shock. And at that point, you're going to want to do surgery. If you did less than 1,500 milliliter, but after draining all the blood, you come back like an hour later and there's over 300 milliliters still in there because there's a continual bleed, then you're worried about one of the arteries being hit, and that is concern for surgical intervention. Your second chest wound as well is you're going to want to decompress it and do an occlusive dressing. This will have like a 3-way patch kind of deal. And your flail chest, several spots broken in 1, 2 or more spots. Your abdomen has tons of issues as well. It also can hold 1.5 liter of blood, which is another magic number for level 3 shock. So you're going to want to be careful in that situation. That's why we're doing fast exams. That's why we do CTs if fast is not diagnostic. So the thing about this, if a liver laceration occurs, you're going to embolize it or potentially do a lobectomy. If the spleen is injured, you are going to want to try and save it as much as you can, even though in my personal experience, I did not see that was done as much. But splenectomy is ultimate choice if you cannot control the bleeding. And in that situation, you're going to want to make sure that you are covering for encapsulated organisms. These are two pictures that I'm putting up right here. If you watch Sketchy, which I'm sure you have, then you would know that the one on the left is H. flu and the one on the right is strep pneumo. You're going to want to also cover an NMEN as well, so next-year meningitis. So moving on to pelvis. So the pelvis is another area where you can have a hidden loss of blood. It can hold a lot of blood as well, so that's why you can get shock without having any exsanguinating lesions on the surface. So if it's the ureter that's injured, then you go on to a pyelogram and a methylene blue, depending on where their operative status is. If the urethra is potentially injured, you're going to do a retrourethrogram, and if there's a rectal issue, you're going to do a proctoscopy. You're going to want to replace the blood. You're going to embolize any of the arteries that are have the cut in it, and you're going to want to follow with serial H and H's. This is hemoglobin hematocrit. Yeah. Lastly, not lastly, but yeah, so extremities also. So if you have like a femur fracture, you're probably jumping up right now saying that you're going to have a fat embolism that goes to the brain, or if it goes to the chest, and you're going to have petechiae over the chest, and you're going to have like altered mental status and all those stuff, and you'd be correct in dyspnea. But another issue you can have is you can have it depending on where the injury goes. Say it was a bullet wound. If it's close to arteries, and you're going to want to kind of explore and see if there's issues there. If it's not, then you don't have to worry about it as much. But potentially there is a spot for a lot of blood to pool there, and you not notice this. And this is another area where you can have a situation where you're developing shock, although there's no exterior exsanguinating lesions. So you want to do a physical exam, a Doppler or a CT angio, depending on how severe the injury is. And here's my works cited of different things I used in order to create this presentation. I hope you learned a lot, and hope it gave it a nice general approach to trauma and how to how to address these issues in the future. Any questions or comments, leave them in the comment section below, and thank you so much for tuning in.